year. Stroke was also the second most common cause of global disability-adjusted life years, and the number of global deaths due to ischemic strokes and hemorrhagic strokes was very high. So this is as far as the epidemiology is concerned. But we may also want to know that why this is important is stroke is a time-sensitive disease. And we need to know that when we need to act, how fast to act, and important is to recognize the symptoms of stroke. So I would like to brief you what do we have at this point of time, the important treatment paradigms which have changed and made a shift in the stroke care from the time where we had just an antiplatelet drug which could be given to the time where now we are working with seconds and minutes, where every second of the ischemic brain which is getting damaged counts. If one wants to divide the stroke, we want to divide it into ischemic stroke and hemorrhagic stroke. Ischemic stroke is predominantly a large artery, that is an atherosclerotic stroke, or a small artery, which we call as a lacunar stroke, a cardioembolic stroke, and then there would be cryptogenic, that is, we do not, with the modality of investigation at this point of time, we do not have a reason which we could point out for the stroke. Or there could be other causes in which the patient can have a large artery thrombosis as well as a cardioembolic thrombosis. They can have a dual pathology. We are going to talk only about the ischemic strokes here. And the other part of the stroke, which forms around 15 to 20% only, is primary hemorrhagic stroke, which includes the intracerebral hemorrhage and the subarachnoid hemorrhage. Ischemic stroke accounts for 80% of the stroke, and the hemorrhagic stroke accounts for 20%. They're different in the form of what is the reasons behind the stroke, that is the etiology, as also the prognosis of this, the stroke, and the treatment modality as well. So what is an ischemic stroke? It is an episode of neurological dysfunction caused by focal, cerebral, spinal, retinal infarction. IC bleed or the intracerebral hemorrhage is a rapidly developing clinical signs of neurological dysfunction, which is attributed to a focal collection of blood within the brain parenchyma or ventricular system, which is not attributed to the trauma. And a subarachnoid hemorrhage is a rapidly developing clinical sign of neurological dysfunction or headache because of bleeding into subarachnoid space. And this is a definition. Ischemia means there is a cutoff of blood. Intracerebral bleed is a focal blood collection. Subarachnoid hemorrhage is blood across the subarachnoid space, if we understand the anatomy well. Now, because this is a clinical forum, I would like to take a case and take forward how one would want to manage the case. Now we have Mr. YM. He's a 62-year-old gentleman. He develops a symptom in which he is unable to hold the book, and he has speech disturbance, that is, he has a dysarthria. He lives next to a hospital and he reaches within 30 minutes of the symptoms. Now, by the time he reaches the hospital, his symptoms gets resolved. That is, he doesn't have the dysarthria and his power in the hand comes back. His past medical history is noted to have hypertension, but when he arrives into the hospital, his blood pressure is 120/80, fair and good. Now we have three major questions which pop up here when the patient like that comes to the emergency, had a symptom, but while he enters into the emergency, he's asymptomatic. And that becomes a challenge. One, for the clinician, that because he doesn't have a symptom, so where are we going to localize the lesion? Second, for the patient, because if we ask for a test, that's a practical problem that they are not willing because he's now absolutely fine. So we have three questions here, which needs to be addressed. That did the patient have a TIA, that is a transient ischemic attack, or he had a non-ischemic mimic event? Now, what is the risk that this event which he had was a TIA, and what is the risk of a recurrent stroke or a vascular event for this patient? Though he's asymptomatic now, what is his prognosis? Third is, now because he had a speech disturbance and he had a weakness, should I be hospitalizing the patient or should I send the patient as an outpatient management care? So how do I go about it? Now there are ways for it. That is, the first question, really what we are looking at is the stroke mimics and the stroke chameleons. The second, what we are trying to do is the risk stratification in the patient. Third, we are going to have an acute decision-making management and trying to prognostify the patient, whether the patient has got a risk and he should be under an observation. So let us look at the first one. There are alternative diagnoses of TIA and mimic patients, all of us know, and of which the toxic and the metabolic part leads the list, of which the disorders of glucose metabolism are the most common ones. The patient could have a hypoglycemia or a hyperglycemia, which could mimic like a transient dysarthria and a limb weakness. The patient could have had a minor seizure, of which afterwards the patient had a little postictal weakness, which is also known as a TOTS paralysis. The patient could have had a complicated migraine in which the patient had a difficulty in talking and the patient had a limb weakness. We all understand that true migraines with auras and migraine without aura, apart from that, there could be a complicated migraine. Or in a different situation in which the history of the patient was different, like the patient had a giddiness and had vomiting, it could have been a peripheral vertigo. The patient had consumed alcohol the previous night and had an intoxicating effect. Differing everything, patient could have just be a conversion reaction, or patient could have a non-epileptic attack disorder like event, which could have mimicked a limb weakness. Neuropathy, a very important cause, in which the patient has got a foot drop or a wrist drop and mimics a focal lesion either in the frontal lobe or in the corresponding homunculus of the brain. A good history of the patient will help us to differentiate between the patient's TIA or the mimics once we find out the biochemical as well as a history, whether the patient had previous episodes, whether the patient is a diabetic, what did the patient do when he had the symptom, whether there's a tongue bite, whether there's an incontinence, where is the lesion, whether he has any sensory deficit along with it, will help us to rule out the other mimics as well. That is about the mimic. That is, a patient's symptom looks like a stroke, but the patient is not having a stroke. That becomes a TIA or a stroke mimic. Now we look at chameleons. That is, the patient really has a stroke, but is mistaken to have another disorder. Like a patient comes with a vertigo and the patient is framed as a benign paroxysmal positional vertigo or labyrinthitis, that is a peripheral vertigo. A good examination with a nystagmus will help us. A monoparesis with a focal cortical lesion mimicking like a foot drop or a wrist drop. An acute confusional state, all of us know, a Wernicke's aphasia, a temporoparietal stroke, acute onset, or a thalamic can present with an acute confusional state without any limb weakness, but looks like a patient with an altered sensorium. Patient can have a sudden memory disturbance, but could be a bilateral thalamic infarct. Patient can have something known as a limb shaking TIAs, looks like a seizure, but there are multiple TIAs in progression, which should be carefully monitored. Otherwise, the patient can go into full-blown stroke. A capsular warning syndrome, that is a basal ganglionic lesion in which the patient can have a hand, leg, or the face without any cortical symptoms, that is any aphasia in either in turns. One time the patient has a motor phenomenon, one time patient has a sensory phenomenon, one time the patient has a facial sensory symptom. It looks as if the patient is mimicking or the patient has got a psychogenic lesion, and because of which the patient is framed to have a non-stroke event, but could be a stroke, that is known as a capsular warning syndrome. So one should be very wary of the chameleons, but all of them, if one takes a good proper history, can find out with minimal signs and symptoms which could lead to the primary diagnosis. When we are talking about TIA, there could be three in nature. One is a large artery, that is a low flow TIA, in which we are talking about the large blood vessel having a plaque, producing a significant big disturbance in the blood flow. They're usually short-lived, they occur for minutes, and they're often recurrent, and they occur once per week, or they can have several times in a day. If you have short-lived recurrent same semiology, then one should be looking at a large flow, low flow TIA, and they can produce a full-blown stroke, and one needs to get a carotid and vertebral Doppler and an intracerebral angiogram for this patient. That is why the type of TIA in the history is very important. Embolic TIAs, either it could be from the heart or it could be from the any of the atherosclerotic plaque, that is a thromboembolic phenomenon. They're usually longer lasting. Now, this low flow TIA that we said that the patient of our prototype patient, he had a short lasting, he had just for half an hour. I would say within half an hour, by the time he reached the hospital, he was asymptomatic. The embolic TIAs, they usually last hours rather than minutes, as in a low flow TIAs, and they're very infrequent. They're not seen as often. Then we have the lacunar TIAs. By lacunar TIAs, what we mean is that the end-on vessels, which we can see here very well. These are the lenticulostriate arteries. They are the end-on vessels which are producing the lacunar strokes. And in the same way, they are the recurrent stereotype, and they can behave as if in the low flow TIAs. But then once we do a carotid and a vertebral Doppler and an MR angiogram for these patients, we do not find a large vessel occlusion. Then we know that they could be lacunar or small vessel penetrating TIAs. This could present as a capsular warning syndrome. As I said, with these small vessels, sometimes they could be a sensory TIA, one time they could be a motor TIA, and they could be in various forms, and they are stuttering and they keep building up in nature, going on to produce a full-blown stroke. So the next we want to know about what is the risk of a recurrent stroke or a vascular event for my patient. Is he going to develop another event? Is he going to develop another stroke? So need to stratify that. And for TIAs, we have a risk stratification score that is an ABCD2 score, in which A stands for age. All of you can download this on your phones. You don't need to really mug up that, but we need to know that what are the important salient points which really increase the patient's risk of having a stroke. You have that ABCD on your phone. You just need to click yes and no, and the score will be there on your phone as well. So age, blood pressure more than 140, clinical features of TIA, either unilateral weakness without speech impairment without a unilateral weakness, TIA, which is a duration of more than 60 minutes and a duration of 10 to, and the duration of the TIA is also important here. We understand that. And a diabetes. So the total ABCD score would be from 0 to 7. And we have other tools in our box, that is the imaging, either a CT scan or an MRI diffusion weighted imaging and a vascular imaging. So let us see where our patient falls into. Our patient was more than 60 years, so he gets a 0.1. Blood pressure was normal, it was 120 by 80, so he gets 0 there. He had both a unilateral weakness and a speech impairment, so he gets a 2. He had a TIA duration which was less than 10, it was 10 to 59 minutes, that was around 30 minutes. So he gets a score 1. He was not a diabetic. So total, his score runs to 4. So we have risk stratification for an decision-making and a prognosis in this patient. This all takes minutes for us to do. If we understand that the patient had a TIA, and we need to manage and tell the patient also that what is his risk of getting another stroke within days, within a week, or a 3-month time. So our patient falls under ABCD2 moderate, 4 to 5, and his risk of having a 2-day risk of having a stroke is 4.1, and a 2-day risk, that is a 1-week risk, is around 6%, and a 30, that is a 3-month risk, is almost around 10%. That doesn't mean that this is if the patient is not properly treated. So if the patient is treated properly, if we have identified the TIA, and if we have treated properly, then the patient does not have this risk. That's why he falls under a moderate risk. So you do a full neurological and cardiac examination, which was earlier done. You are going to check the pulse rate and the rhythm, and you're going to put him on the monitor, because lone atrial fibrillation or an intermittent atrial fibrillation is one which we are trying to look at this patient, because as we said, TIAs could be cardioembolic. You're monitoring his blood pressure, because one blood pressure checking at that point of time would not be enough. You run the bloods immediately, you check his CBC, platelets, you check his coagulation screen, sodium, blood glucose, and a lipid profile. Sodium and blood glucose is to see if there are any mimics. You check his ECG, echocardiogram, carotid and vertebral Doppler, and you go for the neuroimaging. These are the basic investigations one would always want to do for any patient with a confirmed TIA, or if the patient has a mimic and we want to know the alternative diagnosis for him. So Mr. YM has a cardiac and neurological examination, which is normal. He doesn't have atrial fibrillation. His blood pressure is normal in both the upper limbs. His blood investigation, ECG and echo are normal. His carotid and vertebral Doppler shows an 80% right carotid stenosis, and his MRI shows a right frontal diffusion weighted image positive. So now, is this patient a TIA, or is this patient having another diagnosis after we have this investigation with us? Is there a chat box here to put in their answers?
Ma'am, we do have a chat box.
Yeah. If you could just pin in, do you feel, how many of you feel that this is a TIA, confirmed TIA now? Or does he get another diagnosis at all? Okay, fine. That's okay. So with the given investigations now, he has a TIA. Okay, we understand, because he had a symptom which was very classical. He had a weakness. He had a speech disturbance. He had difficulty in holding his holding the object. He came. His other parameters are normal. His stroke mimics have been ruled out. But what is different here now, though his neurological examination is normal and he's no longer symptomatic, his MRI is showing a right frontal diffusion weighted positive, that is a right frontal infarct. In the setting of a right frontal infarct, his diagnosis is not a TIA. And now we move from the diagnosis and a discussion from an older definition, which is a clinically based, that is time-based, I should say, to a tissue-based. That is, a time-based was earlier diagnosis of TIA was a brief episode of neurological dysfunction, which is less than 24 hours, resulting from a temporary cerebral ischemia. And we move on to something which is a tissue-based, that is, even if the symptoms have lasted less than an hour, there is a transient episode of neurological dysfunction without an acute infarction, which could be concerned have gone through various trials, from the Express, Match, Master, Chance, and the last one is a point trial. And I would just like to highlight here that all of these analyses suggest that in patients with acute minor stroke or TIA, we need to initiate a dual antiplatelet therapy with as soon as possible, and preferably within the first 24 hours, and they need to be continued for a duration of 21 days. So the last point trial had come to this conclusion. So as far as YM is concerned, one should not leave out counseling the patient about the lifestyle interventions. He gets a dual antiplatelet therapy, he gets a statin, his antihypertensive is rechecked and put in place. Because he has got an 80% stenosis of the carotid, he goes to the interventional neurosurgeon, and he is planned for a CA or a stenting. And that should be done as early as possible, given the possibility that he had a 9% risk of a stroke within the next 3 months. And he is also asked for a regular follow-up. Counseling part should never be left out, because most of the time, because the patients have reached normalcy, it is probable and possible that they are going to stop the medication, and that would be catastrophic for the patient. Now we come to another scenario where again, time is brain, and there the time is ticks very, very fast. We have a 65-year-old hypertensive and diabetic. He develops a left hemiparesis, a facial deviation, and a dysarthria since the last 1 hour. His blood pressure is very high, is 200 by 110 millimeters of mercury, and his sugars are on the higher side, 184. Now, what does one do? Should we give him an aspirin immediately? Because he looks like a classical stroke. He has a left hemiparesis, facial dysarthria, all localizing to the right MCA territory. He is 65 years. He has hypertension. He has diabetes. His risk factors are there. His blood pressure is very high. His sugars are very high. Would you be giving aspirin to this gentleman? Would you be giving an antihypertensive because his blood pressure is very high and it is imperative that he has come to you? You need to address the situation which is shouting out at you. Would you want to just keep him in your clinic and observe him for some time so that his hypertension settles down and treat and then shift the patient? So you have these various scenarios, and these various scenarios are what happens in our country and in every country, I suppose, when the patient goes to a step care therapy. He rushes to the nearby hospital, which is convenient to him. And at that point of time, the physician has to take a decision as to whether to keep him there and check out for his symptoms which can be treated at that point, or he has to shift him so that he gets the best of the care. So there are certain do's and don'ts one should understand, and that can indeed be catastrophic if the patient is undergoes those treatment at that point of time. As we understand, the patient has a symptom of 1 hour. He has been very good. He has understood his symptomatology, and he has come to the hospital for the best of care. So the do's and don'ts are, at that point of time, one is not supposed to give an antiplatelet and an aspirin. No pharmacological intervention should be given unless the patient is having a malignant hypertension. That is, the patient looks like in failure, or the patient has symptoms which are suggestive of aortic dissection, until and unless the antihypertensive are not to be given even for this blood pressure. Admitting and observing for a hypertension would not be advisable for the simple reason that you're wasting on time. Time is extremely crucial, and we will see how we are going to help the patient the patient to reach the hospital as fast. Shift, that depends. If you are in a comprehensive stroke care unit, if you are in a primary stroke care unit, or you are in a center which can give a thrombolytic therapy, then there is no need to shift. But then you are supposed to shift, but you are shifting. You need to document the time of onset. You need to document what was the medication, and you need to have a physical examination which focuses on speech, facial droop and drift, and then transfer the patient, because we need to know from the time of the first assessment to the time of the EMS entry, what was the symptom and what is the progress of the symptom. And it is always important that whosoever is transferring the patient, whichever hospital he is transferring, there should be a notification to the receiving hospital so that the MRI or the CT console is kept free for a potential patient who needs a thrombolytic therapy. So we are looking at a stroke care in which we have a stroke care pyramid. This is a basic care hospital where the patient can have an assessment, can have an identification. He can be stabilized for ABC, and he needs to be transferred. When he is transferred, as I said, he needs to have the basic neurological examination, just the facial droop, the limb power, the blood pressure, the sugars, and then notifying the hospital. This is the acute stroke ready hospitals in which the hospital is equipped with a CT scanner, can have a patient's CT scan, can rule out that there is no bleed, can know that there is an ischemia there, can get an IV a thrombolytic therapy, which could be done via a telestroke, which is connected to this primary stroke centers. And this is being done in the country where the acute stroke ready hospitals are more and more acute stroke ready hospitals are developing, because the primary stroke and the comprehensive stroke care centers are way away from the patient care, because we are talking about a country which is urban as well as rural, and this rural patient probably might find it easier to reach either this place or this place rather than reach this place. The primary stroke center, there is a stroke unit and a coordinator, stroke service, and a continuum in patient care. And a comprehensive stroke center has everything. It has called all the facilities of a primary stroke care center function, plus a neurosurgeon and neuroendovascular. So this, one could always have a ship and drip method. That is, the patient gets a TPA and then is immediately transferred either to the primary or the comprehensive stroke center. One may want to know that if the patient has already received a thrombolytic therapy, then why can't he just be managed at the acute stroke ready hospitals? We'll come in the next slides that the treatment part of the stroke does not end there, even after the patient has received a thrombolytic therapy, because time is brain, and every minute and every second you're wasting, you are losing on the salvageable tissue. So what are we trying to do to the acute stroke patient is three. We are trying to recanalize the occluded vessel. That is, there is an area which is infarcted, and there is an area surrounding it which is hypoperfused, but it is still viable. It is only ischemic, and that is salvageable. So if you recanalize this occluded vessel fast, it is going to reach the area and help to perfuse the ischemic area, and the salvageable tissue can be salvaged. The other is you are trying to optimize the collateral flow. Now this is the area, and this is the penumbra, which we are seeing here. This is a light brown, and this is the core area, which has got already infarcted. And this is the large area which you're trying to save. So this is the occlusion, which is the recanalization, which we are trying to open up the vessel and trying to give flow to the whole area. Or the collaterals, we know that it's like a branch. It's like the circular villus has got multiple collaterals which come from either side. And those areas can come from outside and try to help the penumbra area. And you're trying to optimize that collateral flow so that the recanalization as well as the collateral flow, both of them help to temporarily preserve the ischemic penumbra. And then obviously you're trying to avoid the secondary brain injury in that patient. So the prompt reperfusion is what we are trying to do to help to see that the salvageable tissue can be helped off. So as the time passes, you can see that the center part is the core, and you can see that as the time passes, the core expands, and the penumbra and the olebic area, which we are trying to see, I can try to go back again. This is the area. So this is the core part here. And as the time passes, you can see that the core increases and the penumbra and the oligemic area becomes smaller, and the infarcted area becomes bigger. So time counts per minute, around 1.9 million neurons are lost, and the accelerated aging for that patient increases as well. And the estimated pace of neuronal circuitry loss in these patients, around 14 billion neurons will be lost in that minute. So time is absolutely important. And as the patient is moving forward and increasing his, the penumbra and the oligemic area is getting destroyed more and more, this is the way a stroke unit functions. That is, the patient reaches from the door to the needle. So we say the D and T, the door to the needle time. The patient reaches the door, the physician sees him within 10 minutes. Then the door to the stroke team is alerted in another 5 minutes. In another 10 minutes, the patient reaches the CT scan. Another 10 minutes and another 20 minutes, the patient has the CT scan interpretation. And we take another 10 minutes for counseling the patient and the relatives, and the patient gets the drug. That is a door to needle D and T is within 16 minutes. There is something known as the NIH stroke scale, that is the National Institute of Health stroke scale, in which this is a form of scale which is a general management which tells us about the stroke outcome measures, which is strongly influences the baseline stroke severity of our patient. This is NIH stroke scale, which has 11 points in it. The total score is 42. And as the number increases, we know that the patient's severity of the stroke is more. It helps us to communicate across borders, the same way as the Glasgow Coma Scale goes. So you need not say each one in particular. You tell about the NIH stroke scale. He has got around 30 NIH stroke. I know that the patient is extremely sick, and whether I can give him a thrombolytic therapy. It also helps us that the patient's NIH stroke is very bad. Then the patient has got a large stroke, and the chances of bleed for that patient might be very high. It also has an objective measurement, that is, once you are given the thrombolytic therapy, whether the patient has improved or not improved, the same way as you do for a Glasgow Coma Scale. So what are the other things on the ground and during transport? All patients gets a peripheral venous catheter, which is placed in all patients. You need to avoid the paretic arm for the placement of the catheter, because that is an immobile arm and can have venous stasis, and also patients require intensive physiotherapy at a later point. You need to elevate the upper body to around 30 degrees. If the patient has got hypoxia, the patient needs to have oxygen, 4 liters per minute, and one should be avoiding the oxygen in the COPD patients, as we all know. One should not be instituting any form of antiplatelet or antithrombotic therapy unless we have a cerebral imaging in place, and we know that the patient is not a candidate for a thrombolytic therapy. If the patient's blood pressure is less than 220 and less than 120, no immediate action to be taken. If the patient has a hypertension of more than 220 and 120, I will come in the next slide, where we have intravenous antihypertensives which need to be initiated, because a 220 by 120 might be more than 220 by 120 could be a contraindication for a thrombolytic therapy. For the chances of bleed in that patient would be very high. If the patient has arterial hypotension, we need to bring up his blood pressure. If he has hypoglycemia, then he needs to have glucose, which is less than 60. Hyperglycemia, if it is more than 300, then he gets an insulin. Again, if the patient has got severe hyperglycemia, the chances of bleed in this patient would be very high. So before you are instituting the thrombolytic therapy, you need to check the blood pressure and the sugars are under control, and that can be brought down by the IV intravenous antihypertensives as well as the insulin in place. If you are taking too much of strenuous efforts to bring either the hypertension or the sugars under control, then you need to take a decision whether you're really justified in giving a thrombolytic therapy, again, because of the chances of the bleed can be very high. So you have the imaging report with us. You have the patient has got a characteristic diffusion weighted imaging, which has got an ADC, and you can see here there is a right middle cerebral artery. We can very well appreciate here. It is not seen, as well as you can see the collaterals which we were mentioning here. It's not at all seen in this patient. So coming back to Mrs. AM, she has got an NIH stroke scale of 8. The time from the onset is now 2.5 hours. She reached by 1 hour to the hospital premises, as we all know. There are no contraindications. There's a contraindication and an indication chart, which we quickly look at, and a right MC infarct and a right MCS stenosis. Now we need to thrombolize the patient, and we start the time clock. We have 3 interventions, which is the medical treatment, the common medical treatment. We have the thrombolytic therapy, that is the tissue plasminogen activator and the tenecteplase. And we have the endovascular therapy. Now, which one should we be giving to this patient? As I was mentioning earlier, if the patient is an eligible candidate for intravenous thrombolysis but has a high blood pressure, we have intravenous antihypertensives with labetalol at 10 to 20 milligrams over 1 to 2 minutes, which can be repeated over 1 minute, or nicardipine, which is at 5 milligram per hour IV and titrated to 2.5 milligram per hour. Again, as I said, if we are taking too many steps to bring down the hypertension, and the hypertension is sort of a malignant hypertension, then one needs to reconsider whether the patient should be given a thrombolytic therapy, because again, you're losing on time as soon as you progress forward. The time for a thrombolytic therapy is from the patient's time of symptoms, that is equals to receiving the drug, that is the needle time, is 4.5 hours. More than 4.5 hours, as far as the indication goes, you cannot give the patient. But I will come in the next slides how from the time to the tissue we are moving into, the way we moved into TIA. But in general, 4.5 hours is a window period time for us to institute the thrombolytic therapy. That is why from the door to needle time has to be kept as minimum as possible. And in the best of centers, it is at 30 minutes. So you can understand when the patient reaches the hospital, gets the cannulation, gets all the investigations, which includes the primary blood tests, which includes predominantly the creatinine, the CBP, and the coagulation profile, gets a CT scan and an MRI, whichever is the protocol for that particular hospital, gets an ECG, gets the CT scan reporting done, comes back, reporting, and the pros and cons of a thrombolytic therapy is explained to the patient's relatives. And what needs to be explained is that the patient has got an ischemic stroke. He falls under the window period where there is injection, which is a clot buster, which can lyse the clot, and the chances of the patient being better than a patient who has not been given a thrombolytic therapy at 3-month time. We are not speaking at the 0-hour time. At 3-month time is 30%, 20 to 30% better than a patient who does not. So we understand that there is a huge window. So, but then there is always also a possibility that the patient can have an IC bleed, which could range from 1 to 4. If his NI stroke scale is more, then the chances of bleeding are more. But in general itself, it is 1 to 4%. And the patient and the patient might not, the relatives need to take a decision at that point, whether they give a consent. So once you have counseled and then you're given a consent, then a thrombolytic therapy is given. So you understand that everything, every time the time is ticking, because while if the patient comes at 3 hours, let us say, or 3.5 hours, then 4.5 hours is the window period. You take 1 hour, and by the time you're counseling the relatives, it becomes very difficult because they are not able to take a decision and the time is running out. And if they take a decision at 4 hours and 45 minutes, then are you justified in giving a thrombolytic therapy? So the door to needle, we need to keep it as sharp so that we give time for the patient relatives to understand, seep in, and give a consent to you. So what are the thrombolytic therapy we have at this point of time is one is alteplase and one is tenecteplase. There is a difference from where we started from slow and infusion, that is alteplase. We give it for 1 hour, where we come to a bolus injection, that is a tenecteplase, as a 1-shot bolus injection. So to know the difference between alteplase and a tenecteplase, the most important characteristic feature one would want to know is that one is the fibrin specificity. Alteplase is at 2+ and tenecteplase has a 3+ fibrin specificity. Second is, this is given calculated dose is 0.9 milligram per kilogram body weight, and of which 10% is given as a bolus, and over the next 1 hour, the patient receives the drug. Tenecteplase, it gives as a 0.2 milligram per kilogram as a single bolus dose. Also, we need to understand the cost factors between the both, and also that this is approved, alteplase is approved till 4.5 hours, and tenecteplase as of now is approved for 3 hours window period stroke. So if the patient falls between 3 to 4.5 window period stroke, then we may want to give alteplase rather than tenecteplase. So we have thrombolized our patient. Luckily, our patients, Mrs. Ames' relatives gave consent. The patient power improved. The patient NI stroke scale became 2. She was admitted to the stroke unit where she was closely monitored for hypertension, for any bleeding parameters, whether she had any epistaxis, whether she had any hematuria, or she had any bleeding gums, because as we understand, it is a clot buster. Thrombolytic therapy can produce any, her NI stroke was closely monitored, as also her Glasgow Coma scale, to see whether the patient has any fluctuating sensorium, One, to see for any progression of stroke which can happen, even though we have given the thrombolytic therapy. Or second, if the patient has got any IC bleed within the infarcted core zone area as a complication of the thrombolytic therapy. As for Mrs. AM, she did not have any. And on follow-up after 3 months, she was ambulatory and her modified Raynaud skin score is 1. And she is able to carry out her activities of daily living by self. So this is the timeline where from 1995, where the tissue plasminogen activator was approved for stroke therapy within 3 hours from the symptom onset. We have moved on from there with the ECAS 1, 2, Atlantis A and B in 95 to 99, where it was confirmed that 3 hours of window period with multiple studies, it is beneficial. And all of us started giving it more frequently because the data and the research were positive towards that. Then the ECAS 3 extended the time window from 3 to 4.5 hours. From 2008, the stroke window period for 4.5 hours gave a leverage for the, but having said that, though it is 4.5 hours, earlier given is better, because we have seen in that slide that every minute, billions of neurons are constantly being lost. And what the patient disability at that point at 3 months or in his lifetime, we are going to increase if we are going to delay the thrombolytic therapy within the 3 to 4.5 hours window period as well. In IST 3 in 12, more than 80 years were also included, and a wider range of blood pressure was also taken into account. And then in 2019, again, there came a difference, that is 4.5 to 9 hours stroke onset or wake-up period. Now, this is because Mrs. AM comes when she was awake and she was working. She comes with a history of dysarthria and a hand weakness, or if somebody comes with any focal neurological deficit while the patient is up and about and a bystander or a caregiver has witnessed that account. But what if the patient was sleeping? What if the patient stays alone and we don't know the time of the ictus? So that is known as a wake-up stroke, and there we come from the area where the time in the TIA, as we said, from the time we moved on to the tissue. From here itself, here also we move from the time period 4.5 hours to having an imaging parameter, which tells us that the patient could probably fall under the 4.5 hours period, because we don't know what time the patient slept and what time the patient was found normal. So there could be two things. If the patient did not improve after intravenous thrombolysis, so what could you be doing? Or if she presented after 4.5 hours. So this is the patient of ours. The patient has, the vessels got recanalized. You can see that she had say this is just a representative image in which you see that the patient's MCA stenosis has not improved after you gave the patient intravenous thrombolysis within the 4.5 hours window period. And the patient has not made substantial neurological and clinical improvement as well. So what next? Do you have anything to offer this patient again? So the patient can have 3 parameters after recanalization. There could be a successful reperfusion and a tissue salvage, as we saw for Mrs. AM. She improved. There could be no reflow, or there could be reperfusion could happen. This is a no reflow. This is a second representative image. The patient did not improve clinically as well as in the neuroimaging parameter, as well as the MCA is completely stenosed. Or the patient can reperfuse and can have a hyperperfusion. As we said, the patient can start bleeding into that area and then can have a hemorrhagic transformation of the infarct. So then we move from the time to tissue in the acute ischemic stroke as well. Even if we have crossed the 4.5 hours period, the patient has got a large vessel occlusion, the patient has been given an intravenous thrombolysis, but then the patient still stands a chance of getting a stroke being bettered, and that is known as a bridging therapy. That is, you give a thrombolysis alone, patient improves, okay. Patient, you give a thrombolysis as well as thrombectomy, that is known as a bridging therapy, that is an endovascular clot removal for the patient. So let us review the concept of penumbra again. So what we are looking at is this core again. We are looking at this penumbra alone. So we have, this is the core which we probably cannot do, and that is a reversible ischemia for this patient. And this is what is going to produce a deficit for this patient. But as time is passing and we have given him the intravenous thrombolysis, the core has increased and there is a penumbra level there. After having given the intravenous thrombolysis, how do we justify, how do we know whether the patient does have salvageable tissue, which we can intervene? So we have a CT perfusion parameter here. In fact, when a patient has got a large vessel occlusion, as we have seen in centers of comprehensive stroke center, the patient immediately undergoes a stroke CT perfusion study, though I have put it in block forms here that he goes like this, but he undergoes the CT perfusion at that point itself. And these are the two images. So if you would just look simply that this is a core image, which is ischemic core, and this is a green, fluorescent green, which is at risk for infarction, that is the penumbra, that is the salvageable tissue. So if you would try to superimpose, you can see that there is still a large area which can be salvaged, which can be protected, which can be cured, which can undergo a treatment. But if you look at this patient, if Mrs. AM has a CT perfusion study, which like this, if the patient has got a already develops a core which can be superimposed or overlaps on this, then it becomes a large ischemic core and overlaps the perfusion deficit. And this patient cannot be salvageable. The patient cannot undergo mechanical thrombectomy, even if the patient has got a large vessel occlusion. So the patient should receive an endovascular therapy. One may want to say that why to give intravenous thrombolysis if the patient had a large vessel occlusion? Why not give a without bridging, whether to give an endovascular therapy from the very beginning? And there are different centers and different thoughts, different areas, different teams which work in a different manner. We usually use the bridging therapy. We give an intravenous thrombolysis, and we find that most of the times, in 50 to 60%, there is a good recanalization. Patient need not undergo. So these are the criteria one would want to follow. The patient's pre-stroke modified Rankin scale should be 0 to 1. A causative occlusion, there should be a large vessel occlusion, either it is an ICA, proximal MCA, or it is a basilar. Age more than 18, should have an NICE stroke scale of more than 6, an aspect score, which is an Alberta Stroke Program early CT score, in which there are well-defined. There is a computerized program in which the number of areas which are infarcted will come out, and it should be more than 6, and treatment can be initiated within this period. So how did we go? We went from CT, we went to CT or an MRI, we gave an intravenous thrombolysis, patient did not improve, patient improved, patient goes to the stroke stroke care, stroke ICU. If not, again, undergoes a CT perfusion, saw a salvageable tissue, undergoes a DSA and an endovascular therapy and a post-intervention DSA to see the TICI score is good. So the time is ticking out, and we are looking at endovascular therapy from which time to which time? So 0 to 3, we know that one injection can be given. 0 to 4.5 hours, we know that thrombolytic therapy can be given. We also know that wake-up strokes can be given for a bigger period of time. If we have a diffusion and a flare mismatch, that is, a flare is not showing, and we know that a tissue imaging suggests that the patient is in 4.5 hours. So now we have the 2018 two very important trials which came out, that is the DAWN and the DIFFUSE-2 trial. The salient features of both of them were that thrombectomy could be performed at 6 to 24 and 6 to 16 hours if there is a mismatch between the deficit and the infarct. So you see from where we started at stroke treatment with nothing to offer to the patient before 1995, now at this point of time where we stand is at 24 hours also the patient has had an acute stroke and has a deficit and falls under the criteria whether the patient can receive the therapy. He needs to be shifted to at least a comprehensive or a stroke center where he can undergo the required treatment modalities for stroke. So to sum up, time is brain. Whether it may be a TIA, whether it may be an acute ischemic attack, even for hemorrhage, you need to move in the same manner. We are sticking to the ischemic stroke pattern. If the patient has a symptom onset at 0 to 4.5 hours, if he is or she is intravenous TPA eligible, we have seen all the indications. If he is eligible, then he gets IV tissue plasminogen activator or a tenectase at 0.9 milligram per kilogram body weight at 10% and rest over the 1 hour, or tenectase at 0.2 milligram per kilogram as a bolus dose. If he is not, then if he has a contraindication to IV TPA, then he goes for a CT angio and CT perfusion study, and where his aspect score and a nice stroke scale, and there is a perfusion mismatch, then he goes for a mechanical thrombectomy. After thrombolysis, still he has got a large vessel occlusion, whether it is an IC or M1 or the basilar, then again, if he has a CT perfusion study and if he's eligible, then he still gets to undergo the mechanical thrombectomy, provided you have properly counseled the patient and you have explained the pros and cons of the therapy to the patient. So the hallmark of stroke treatment is prevent, reperfuse, and protect. Reperfuse, as a medical fraternity, all of us at every point of time should try in our own ways to engage with the public and try to guide them with the stroke warning signs and symptoms, because until and unless they recognize the stroke, they will never reach the hospital. At least they reach the hospital, it could be a primary center where they could be transported to the comprehensive and the stroke-ready hospitals. So we have intravenous thrombolysis for eligible patients between 3 and 4.5 hours, and endovascular therapy, which is extending to almost 24 hours now in select patients. One should not forget that treatment, though it is a goal, prevention still remains, because prevention is always better than cure. And I would just like to say that from Dr. Bindu Menon Foundation and from part of Apollo Hospital team, we have started a stroke prevention campaign, which is going to run all through the year, where every one risk factor is going to be addressed in each particular month. And one can always join us in our stroke prevention campaign and possibly share it with their colleagues who are especially non-medical colleagues. If one wants, can scan this QR code so that it may be easy to share it with people. Thank you very much.
Thank you, ma'am. It was really informative and amazing. Now we can have some questions. The participants who have any doubt, they can raise their hand and then they can unmute themselves and ask it out to ma'am. So we can proceed. I repeat, any participants who have any doubt, they can raise their hand and then they can unmute themselves. Else they can also do one thing, they can put their doubt in the chat box.
Thank you very much then.
Yeah. Now, thank you, ma'am. Now I'll hand over it to our president, Bhavya Pava.
Thank you, Mohit. Ma'am, I couldn't be more than happy. I mean, the way you were teaching, I really wish, like, you know, everyone who's teaching us right now in medical schools, they like either learn something from you, how to teach us, or maybe like someone like you can, like, you know, teach everything to us, because I believe that, you know, in med school, it's really important that we are taught in the exact manner that how you taught us today, and the way and the calmly and the warmth that we felt with you. It was really nice. And ma'am, I'm really, really thankful to you that you took out time for all of us today and to make this wonderfully beautiful presentation. And thank you so much, ma'am, for your time. I guess we don't have any questions. I'm just looking at the chat box. So I guess we don't have any questions, and thank you so much, ma'am.
Thank you very much, Bhavya. Thank you for making me a part. And as I said, I'm very happy to see that there are so many aspiring neurologists and neurosurgeons, and I wish them all the very best in their future.
Thank you so much, ma'am. Thank you so much, ma'am.
Bye-bye.
Thank you. And for the other participants, it's a request that you don't leave the meeting because we shall be sharing the Google form, the feedback form, so that you are eligible for the certificate. One of my national officers, Christina, she has shared the form in the chat box. I shall be waiting here for 2 more minutes before ending this meeting so that all of you can be redirected to the Google form, and we shall be closing in another 2 minutes. Thank you, everybody. Next up, we shall be having talk of Dr. Salim Abdulrauf, who's our patron for Walter E. Dandy Neurosurgical Club. And he's a mastermind behind this, who recruited and hired all of us to start this club. So stay tuned, everybody.